Hi, welcome everyone. Hopefully you can see the slides. Is that everyone can see that? Is that okay? Oh.
Excellent.
Yes.
Okay, so that's okay, great. Hi, welcome everyone. It's really wonderful to be here. We're really excited to finally get to do this CPPD SIG. I'd just like to briefly introduce our group and also note that we will be recording this session. So this is the membership of our group. I'm a rheumatologist working in New Zealand. My co-chairs are Sarah Tedeschi from the US and Abhishek from the UK. We've had a really fantastic fellow, Ken Kai, who's done much of the work, and also two really supportive and insightful PRPs, Owen Henze and David Grossberg. And we're supported by a number of other members of our working group, as you can see here as well. I'm just very briefly going to provide a little bit of introduction around CPPD. This is also available on the videos, but just really to point out the core aspects for those who perhaps aren't so familiar with CPPD as a background for our discussion. So CPPD is a form of crystalline arthritis caused by CPP crystals that form within musculoskeletal tissues, including fibrocartilage, synovium, capsule, and symptomatic arthritis caused by CPP crystals in the joints is called CPPD. So some people will have asymptomatic deposition, but what we're really interested in for the purposes of this group is symptomatic disease. So it has some clinical similarities to gout in that it's a crystal arthritis, but it is really distinctive from gout, which is the other major crystal arthritis. And the diagnosis relies on symptoms, synovial fluid, and imaging tests. And we've just shown some of these appearances on the slide. So one of the challenges around outcome measures for CPPD is that there are different clinical presentations and also treatments. So many people with osteoarthritis or with CPPD will have osteoarthritis. So it often associates with osteoarthritis, but it can also associate with osteoarthritis at unusual sites and flares of acute arthritis. There's also acute CPP crystal arthritis, and this is previously known as pseudogout. And so this is a clinical presentation of sudden onset of an acute inflammatory arthritis, so joint swelling, pain, warmth, redness, and this resolves over a few weeks. Some people will also have chronic CPP crystal arthritis, which is a chronic inflammatory arthritis, and some people will also have spinal involvement. Now, some people may have one more than the other. Some people will have all of these different presentations. So this is really quite a challenge when we're thinking about how to measure outcomes for people with CPPD. So on the website, hopefully you've already seen the videos from David and Owen, but we have asked them to really just briefly provide us with some comments about their experience of CPPD, which I think will really just sort of ground us and help us all understand the experience of CPPD from the patient perspective. So David, perhaps if I could ask you to just make some comments, and then we'll follow up with Owen. Thank you.
Hello, everybody. It's cool to see such a great audience all around the world. I've been healthy, working as a cardiologist in very busy practice, 60 hours a week. And after my father's death 7 days earlier, I flew to a funeral, got a lot of mosquito bites, went back to Maryland, saw 20 patients. The next day flew back to see family, and suddenly, truly suddenly, couldn't walk around the plane, and was admitted to a tertiary care hospital for 2 weeks, Tmax of 101, SED rate of 92, HSCRP of 220, white count of 21,000. And they thought I had various infectious processes. My spine was the most painful site, but I just could not turn or move. And they thought I had abscesses in the spine, lumbar and cervical. And they kept treating me with high dose everything, numerous antiviral and antibacterial antibiotics, and nothing was working except IV Toradol and high dose steroids. It was really tough to be on the wrong side of the stethoscope. And a brilliant rheumatology fellow towards the middle of the admission said, maybe this is CPPD, because my clavicle was hot and red, my right knee, and in addition to the spine, and numerous taps and blood cultures and what have you showed nothing. And they just didn't do the histology, I guess, correctly at this big tertiary place, because they weren't truly suspecting CPP crystals. They were expecting bacterial pathogens. And I got better, but I was able to walk with a walker and went home. And then I went back to work 3 weeks later, part-time, and then full-time. And then I said, I can't do this. And I'm off steroids, but on high dose of colchicine and lidocaine patches and a TENS unit and off tramadol and on 3 grams of acetaminophen daily. And it's been pretty tough. But so now I'm disabled and working with you guys.
Thanks, David. Owen, perhaps if you can just take over there. Thank you.
Yeah. Unlike David, I had a much more chronic course in that I presented firstly in 1995 with swelling of my 4th and 5th metacarpopharyngeal joints bilaterally. Subsequently, I was diagnosed in 96 of having hemochromatosis. And at that time, as I said in the video, my ferritin levels were 8 times what one would expect. And after a year and a half of venesection, my iron levels returned to normal, as did my liver function tests, which on a biopsy were pre-cirrhotic before I started venesection. Thankfully, all of that disappeared, but unfortunately, the joint problems have just continued. So I've gone on to develop progressive joint involvement, particularly involvement of my ankles more recently, and also though involving hips, wrists, and shoulders. I've just had 2 ankle replacements this year, which have been very successful. I'm recovering from my second one. I've been lucky. I haven't responded to any treatments that might be talked about for CPPD arthritis in any great way, but painkillers, paracetamol and tramadol have been very effective. And as I said in my video, diphene was magic. It seemed to give me total relief, but unfortunately, I ran into renal problems and I had to stop it. And again, my renal function has almost recovered back to normal. So mine has been a more chronic course. And I suppose through that, I have been able to work, but it has had an impact on my activities, hobbies, etc. And in that I'm quite limited. Hopefully with my ankle replacements, I might be able to walk a bit better than I was able to, and I'm looking forward to that.
Thanks very much, Owen. I think those are really interesting commentaries, because I think that really sort of underscores the impact of CPPD for patients, and also the different experiences as well, which is again, something that we want to be thinking about today. So this is our PICO for our group. So we're looking at adults with CPPD, any interventions as listed here, and controls as listed here. And I think this is really important when we're thinking about the outcome domains. So we are looking at outcomes for both short-term and long-term management. And that's really one of the things that we want to be thinking about with the group. So we have done several pieces of work already. These are well summarized on the website, but I would just like to ask Ken, our fellow, to very briefly outline the results of our scoping literature review and also the qualitative work that we've done, and then we'll get on to the discussion and voting and specific questions and voting. So Ken, take it away.
Oh, thanks, Nicola. I just want to also acknowledge the contribution of Dr. Amy Fuller, who's our qualitative research expert. It's been very influential in how we work through our qualitative research. So we performed our scope and review searching through the databases of Medline, Embase, and Central, and we identified 5,628 papers, of which 112 were included in our synthesis. And we separated our studies according to the predominant clinical CPPD presentations, which based upon the CPPD terminology recommended by EULAR. Now, the predominant CPD clinical presentations were osteoarthritis with CPPD, which was in 47 studies, acute CPP crystal arthritis, which was 24 studies, and chronic CPP crystal arthritis, which was 10 studies, and spinal CPPD. And there were actually 21 studies where the predominant CPD clinical presentation was unclear. This table summarizes the reported outcomes for all the CPPD studies, and we mapped this to the core areas and domains of OMERACT filter 2.1. So within the core area of manifestations and abnormalities, the most common were imaging domains, including joint damage on imaging tests and joint calcification on imaging tests, followed by joint pain and side effects of treatment. Within life impact, response to treatment and overall function were the most common. And what you'll notice is that very few studies looked at the core domains, the core areas of longevity or societal resource use. Next slide, please. We then also performed a qualitative interview study, which was led by Amy. And we interviewed patients with CPPD and their caregivers, as well as healthcare professionals and stakeholders. And they took part in semi-structured interviews to explore potential outcome domains that were relevant to their experiences and knowledge of CPPD. And this was conducted in 6 countries across 3 continents. And so there were actually 28 patients that we interviewed. Oh, sorry, do you mind going back to the previous slide, Nicole, please? There were 28 patient interview studies, and as you can see, there was quite an overlap between the different clinical presentations between each of the patients. There was 21 patients actually had acute episodes of CPP crystal arthritis, 9 had the chronic form, and also 21 had an overlap with osteoarthritis. Next slide, please. We analysed the data using manifest content analysis, and similar to what we did for our scoping review, we then tabulated and mapped the outcomes according to OMERACT filter 2.1. There's actually 2 numbers behind each of the domains this time. The first number represents the frequency of the mapped outcome domain for patient interviews, and the second number refers to healthcare professionals and 1 stakeholder. And what you can see is within the core area of abnormalities and manifestations, once again, joint pain, joint swelling, joint stiffness, and CPD flares were the most common. And within the core domain, core area of life impact, the most common domains were overall function and specifically the ability to perform everyday tasks. And then we did have more frequent domains mapped to societal and resource use, specifically the use of analgesic medications. And there were some differences between the healthcare professionals and patients, with patients more commonly reporting joint swelling, joint stiffness, and range of movement, as well as use of analgesics, whereas healthcare professionals looked at the presence, or more frequently reported the presence of CPP crystals, radiologic calcification, joint damage, and time to diagnosis. And that's it for me.
Great, thanks. Thanks, Ken. So the next step in our group is to go through the prioritization and formulation of the core domain set, as is outlined in the OMERACT core domain set workshop, workbook. But before we do this, we really felt that we had some important questions that we needed to take to the group, which would really help us to work through the work from here. So before the prioritization work, these were really the questions that we need to be thinking about and that we'd like to discuss at this SIG today. So the first is that there are clearly several different CPPD clinical presentations. Should we develop different core domain sets for different clinical presentations? And if so, which presentation or presentations should be prioritized for future work? So we're going to talk about that first. We have another question that we'd also like to talk about today as a group, which is that CPPD and OA often overlap. So how should the group manage this overlap with the already established OA core domains? So we're going to start with this question first, and I think we'll probably have about 15 minutes or so to talk about this one, and then we'll go ahead and talk about the other one. So I'm just going to remind you again that people with CPPD may have often have different clinical presentations. They may also overlap, but there are a number of chronic presentations and also this acute arthritis presentation. So this is, I guess, similar to what we do see in gout. And I just wanted to also show the work that we did do in gout a number of years ago now with the core domain sets as a kind of template of how we might manage this in CPPD. This is not, we're not suggesting in any way that this should happen, but I think that this, for the gout group, this was certainly a very useful way that we kind of managed these different clinical presentations or types of clinical studies, and this may be relevant to CPPD as well. So with chronic, what we termed in those days chronic gout, we had a number of mandatory core domains, which included the acute, what we called in those days the acute gout attack, and these might be the domains that we would use, say, in a long-term, say, 2-year RCT of a nurse-led adherence intervention, for example. We also had a separate set of core domains for acute gout, or what we called acute gout in those days. And here, these are more specific to the flare itself, so joint pain, swelling, tenderness, activity limitation, acute phase marker, and these might be used in a short-term study of, say, an anti-inflammatory medication for gout flare. So that's really just as a kind of background. We are going to vote on this after we've had some discussion, but I'd just really like to open this up now to the question, should we develop different core domain sets for different presentations? And if so, how should we go about that? So I'm just going to open that up to the group now, and please tell us your thoughts. Maybe I'll stop sharing and we'll just maybe be able to see everyone. And
okay, Nicola, I'll say something because once somebody says something, then everybody else will start talking
that's
too.
Great. Thanks, Geraldine.
I just think, based on your description of gout there, I think it would be awfully difficult to not separate the acute versus chronic manifestations of CPPD. Now, you might be able to bundle some of the chronic ones that traditionally were called things like pseudoneuropathic and chronic, like rheumatoid-like and that kind of thing. Perhaps there could be some linkage between them, but I feel the kind of acute pseudogout, or what we used to call pseudogout presentation, probably needs its own descriptions, because apart from anything else, it is so easily confused with septic arthritis, etc. So it's really important, I think, in the clinical setting. So now somebody could argue with that.
Thanks, Geraldine.
And I'm not going to argue with that. I never argue with Geraldine, first of all. But second of all, I think it's a really difficult clinical sort of spectrum to approach, maybe even a little, well, considerably more complicated than gout, I would say. But I do like the idea of acute and chronic. I think what I worry about is people that put too much emphasis on sort of the category of CPPD that you belong to, because we know that those categories are relatively fluid, and people will, some people with pseudogout will end up having a more chronic rheumatoid arthritis like presentation or look more like OA or have a mixture of both. So, but I think that is the most logical and probably would be the cleanest way of looking at sort of two different aspects of this disease.
This is Needy. I'm going to argue against separating, and the only reason I'm arguing against separating is I worry that some of the things that matter in chronic gout get undermined if they're only doing an assessment in acute gout. And many of our diseases that we work in, so for example, I work significantly in the psoriatic arthritis group, have many different manifestations of the disease, and we work to try to encompass all of those different manifestations of the disease that might be present into one setting. And I think it makes it easier to make sure that things don't get forgotten because one is looking at one category and not the other, or vice versa, and to recognize that these are all on a spectrum. So for example, you pointed out in gout, but same thing happens in CPPD, that you have acute on chronic gout flares, and then how does the acute gout actually get assessed in the chronic gout, and then they would go to the little separate onion for the acute gout. And I think it's better that it's all captured under one thing.
Thank you.
Hi, it's Abhishek Nicola. There's
Yeah.
2 comments on chat from Maria.
Oh, thank you. Yes.
Differentiate acute versus chronic, peripheral versus axial.
Yes.
And from Courage, agree with Geraldine, think broad classification should be acute versus chronic.
So I guess just to kind of clarify, and I, one of the challenges that I, having been a gout, I'm a gout person, I have to admit, and I'm very aware that that there is some sensitivity between CPPD and gout, that, the CPPD people, or, CPPD has kind of, this kind of concept of pseudogout is, is a little, unfair to CPPD at times. And I guess that what I don't want to do is just make an assumption that what works for gout will also work for CPPD. So it's really great to have, Geraldine, Anne, who are really our, CPPD experts, tell us what is going to work for CPPD. I guess what I would say with respect to the sort of holistic assessment of CPPD versus the single is really that with respect to the sort of chronic CPPD, I guess what we're really thinking about more is the kind of long-term assessment, the longitudinal assessment, rather than thinking about the chronic course. So for example, within the chronic gout, we actually had gout flares as part of the the mandatory domains that still needed to be measured in gout. The issue was more really around the measurement and how that gets operationalized, say in a clinical trial, for example. Is Will Taylor on the line? Because Will was very involved in this for both, yes, he is there, for both gout and also for psoriatic arthritis. So it would be interesting, Will, to have your comments about how we might do this.
Well, I agree with everything that people have already said, actually. But I would say that if it all depends on the objective of the study that's been undertaken. So if a study is trying to test a treatment of the acute flare, then you're going to need to have some kind of way of measuring the outcome, which may be different from a study that is testing the prevention of the acute flare. So it's logically necessary to have different outcomes for those two objectives. But I do think that the priority should be more towards the prevention and the chronic disease setting rather than the acute setting, because I think that the treatment's much relative. Yeah, I think that's where the main interest is in both gout and CPPD is prevention studies.
David here, as a non-rheumatologist, probably the only one in the entire SIG. I would tend to say I think it has to be acute versus chronic, just initially from a diagnostic standpoint, because people with acute onset of an inflammatory condition are often missed by general clinicians, ER staff, internists, even in an outpatient setting. But then usually you get fulminantly sick and nobody had a clue. They thought I had a bacterial illness, viral illness, rickettsial illness. It's fine. As far as research trials, it then is going to be, how do you treat the acute illness after you make the diagnosis? And then, of course, lapsing into the chronic realm. So I think you'll need two different domain sets.
So can I just maybe, I'm just going to make some more clarification around wording, and then maybe we'll open it up again. So I think maybe I haven't been entirely clear looking at some of the chat here around the chronic versus acute. So perhaps just to clarify, what I'm kind of hearing is that we probably need separate core domain sets for short-term studies for acute CPP crystal arthritis or pseudogout, and then also a kind of more general CPPD long-term outcome domain set, which would capture things like frequency of flares as well. So rather than having one specifically for acute and then for chronic, actually we're really sort of looking at almost the time course of the study, so the short term versus the longer term. Is that a fair assessment, or am I missing the point?
Can I just comment, Nicola? I think one of the really important differentiations to make between gout and CPPD deposition disease is that at least in gout, we have treatments that can get rid of the crystals. With CPPD at present, we don't have similar. It'd be lovely to think in the future that if we did develop something like allopurinol for CPPD, that we'd be looking at it differently. So I don't know whether we should be optimistic, and because whatever we decide now is going to be relevant into the future. So I just wonder, would we consider thinking that we might ever get something that could get rid of the crystals or not? Because that kind of change, because otherwise, well, I mean, the way it is now, we're really looking at things that will reduce inflammation and pain, because you can't get rid of it.
I guess that might still be relevant for a long-term study, right? So say, for example, a two-year clinical trial of colchicine to prevent flares and, disability, that kind of thing. That would still, there would potentially, those outcomes would be quite different to, say, a study of an inflammatory, anti-inflammatory therapy for acute CPP, crystal arthritis, or pseudogout.
Yeah, I think, Geraldine, you're talking about different mechanisms of action, whereas the objective is still the same, which is to treat the chronic symptoms and prevent acute flares. And it may be that anti-inflammatory treatment can achieve that objective. It may not be achievable with anti-inflammatory treatment, but you need a study to show that. And it may be you're right that the only thing that will actually materially affect the time course of CPPD is crystal dissolution, but we can't presume that. We need to create domain sets that will enable that.
What do you think? Anne has worked on this.
I have, and I have just a quick comment. There's a significant proportion, and I don't know what the proportion is because the epidemiology of this disease is so poorly described, that never have acute attacks. Their first presentation is sort of this chronic inflammation or just really horrible osteoarthritis in odd places. So, the sort of what we know about the natural history of gout where you have your first attack and then your second and your third and then develop chronic disease is so beautifully described, but is really different in my experience from what CPPD can look like. So this natural progression that is, as I said, so well described in gout, we don't know, and I think starting somewhere, we're pretty good at managing acute CPP crystal arthritis, in my experience, because we use the gout drugs. It's the chronic that presents major management issues. And again, as I said, some of these people never have an acute pseudogout-like event really at all during their illness. So I think that differential will cover all, or most of the presentations.
So I just got some comments from the people on the chat, so I'd like to bring them in now. So Maria, would you like to you've given us something on the chat. Can you would you like to outline that in any more detail?
I wonder if we by comparing CPPD with gout, if we not fix us in a box that is not so much representative for CPPD. In fact, acute CPPD is the first flare, the initial flare, or any other flare during the disease. And chronic CPPD might be the long term of the disease, as in RA, chronic. Yeah. Some patients are more or less stable. And we need to separate both, I agree with. And we need to have different core domains to evaluate. But we can't identify one patient who has only acute CPPD and another one who has only chronic CPPD. They are a little bit mixed, and even patients with chronic CPPD experience maybe minor flares, which sometimes can be undistinguishable from OA flare, but they have something. They are not always pure chronic.
Thank you. That's great. Leanne, you had you've provided us with some chat. Would you like to expand on that?
Sure, thanks. I mean, I think just actually hearing from our patient research partners first, of their very different presentations of this and how we would include those in a single study. There's no homogeneity in the patient presentations here. So thinking about the outcomes being tailored to studies that should at least have patients that look similar to each other. But then really thinking about the outcome, if we're going in gout, we described how acute gout is important to consider to prevent chronic gout. And I think this was already mentioned by Anne, is that there isn't a clear relationship in that transition from acute to chronic disease.
Thank you. And Vicky,
sorry, it's a little embarrassing speaking in front of this august group, and I'm a patient research partner, so I'm not a rheumatologist. Great. But if the underlying pathological mechanism is fundamentally the same for each disease, and if there is a spectrum of the acute to the chronic, if you were looking at a therapy for a new treatment or an intervention, can you truly separate those two groups? Are they the same disease? And if they are the same disease, I feel that all areas of the spectrum should be included in the domain. And that's the difficulty, and I understand the complexity that brings into the design of clinical trials. But I often feel that if a patient doesn't fit into a particular box, that means that they are excluded from studies of interventions or things that may help them because they don't present with the approved classical form of the disease. So I guess I'm thinking about what is the underlying pathophysiology of this disease, and how you might treat that, and is that going to be significantly different for each group? And the answer may be that yes, it is, and I'm just demonstrating my ignorance of the condition at this point. So thanks for listening.
Thanks very much. I think that's a really important point around inclusivity, and also our assumptions around, around the disease. Georgios, I think we'll just in the interest of time, I'll ask you to speak, and then I think we'll just vote. I don't know that we've necessarily got an agreement, but it would be really good just to see where people are sitting. So go ahead. Georgios?
Hello, do you listen to me? Do you hear me?
Yes, we can hear you.
Okay. I was just wondering, because as you know, there is the ACR and the EULAR task force that are trying to put down some classification. And since we should try to create some outcome measures for CPPD, probably how can I say, the ideal way should be to see what the subset of the disease are going to be and the classification criteria are going to be. So we could create things specifically for these subsets, the new subsets that are going to be created and published. Yes, I think we are going to create outcome domains for subsets of disease that are not going to be the same as the classification criteria.
Yeah, but I think that's a separate issue. And I think also, as in it's a separate piece of work, but also I think that the CPPD classification criteria isn't going to look at subsets. So I don't think that's going to immediately help us, actually. So I'm going to stop there, and we're going to just vote just to kind of see where people are thinking. So I think the question really is should we develop different core domain sets for different clinical presentations? So I think we have a system of voting. So let's see where people are up to. So let's just go ahead. So hopefully you will have all seen your voting. It's come up, so feel free to vote, and then I guess, do we see it, Shauna? Or Bev?
Yeah, as soon as it's done, I can share the results.
Yeah, it's on there. Oh, see the result, you mean. But did you get to vote there?
Yes.
Yeah, great.
So I think we'll just carry on while we're waiting for that. Maybe we'll just because we've only got a short amount of time left, and I want to make sure that we use everyone's time efficiently. I think we've probably, yes, 76%. So what does that mean? Does that mean yes? I think we're kind of thinking overall. And then, so we have some disagreement, but I think overall a sense that from the group that is a reasonable thing to progress. And I think we might actually move on at this point, because I think we've had quite a lot of conversation already around prioritization, and then maybe move to the osteoarthritis question, because I think that's also something that's really that we need to be thinking about, unless anyone has any burning statements. Okay. So the next thing that we just wanted to really kind of try and get our heads around a bit was around how we would manage any overlap with the already established osteoarthritis domains. So there are already OMRACT core domains for hip and knee osteoarthritis, which I've shown on this slide here. So there are many here which are potentially of relevance to CPPD as well. So, we've seen from the patient interviews in particular, and hearing from our patient research partners, that pain, physical function, quality of life are really important domains. And I think it's very likely that in a CPPD core domain set, those are also going to be relevant as well. So many of these are potentially overlapping, as I guess they are for other rheumatic diseases, as well. I think there is a kind of some commonality about what is really important for patients with rheumatic diseases, or at least arthritis. So I guess the question really is for a person who has both osteoarthritis and CPPD, how should the group manage this overlap with the already established OA domains? Should these inform our development of the CPPD domains in a study of a patient with CPPD and OA? Should we be using both? Should we be using one? What do people think?
So Nicola, how is this different from rheumatoid arthritis patients developing osteoarthritis, which happens in about 80% of RA patients? So
I don't know that it is necessarily different.
yeah. So osteoarthritis is a common concomitant condition for every systemic autoimmune rheumatic condition and for every arthritis that's known to human beings. I think that the reason you're raising this and the group is raising this is because there is probably maybe some pathophysiological connection between the two conditions that may be above and beyond what exists in other conditions. So I think from a pathophysiology perspective, this may be important, but I think given the scarce epidemiology studies in CPPD, I think it's a bit, it's even more complicated than the previous question to me, but you might be able to take comfort in saying, well, OA also exists in, 30 to 50% of this condition and, 10 to 80% of that condition and so on and so forth. So I think it's important to recognize OA does coexist and there may be a unique pathophysiological connection between those two that needs to be sorted out by brilliant, smart, basic scientists, and that in outcome studies, one needs to perhaps have a tallying of the OA and the type in order to discern if something didn't get better. Was it because the CPPD, because the OA didn't get better and the treatment was not directed at OA? But in terms of outcomes, if CPPD affects, pain, physical function, quality of life, sleep, and you're focusing on those domains, then if a treatment improves that, then it should improve in patients with CPPD and in patients with CPPD plus OA, although the improvements might differ because there may be more than one disease contributing to it.
Thanks, Jazz. That's really, I think that's really useful. So it may be fine for us just to, accept it and essentially not take that into account. Is that's essentially what you're accepting that there's often an overlap, but that's just something we live with. And if we're doing a CPPD study, we use the CPPD outcome measures alone and a core domain set alone, and that's just okay.
I think that's what I'm saying. I think just like in RA study, when people have fibromyalgia or have OA, I would love to see a separate subgroup analysis in every RA study by fibromyalgia and in every RA study by a concomitant OA. And I have failed to see that after 22 years of biologic trials, and I think they'll be coming. So you may be ahead of the curve here, because I'd love to see that for every CPPD trial, because I think it's going to help improve understanding epidemiology as so it'd be good to put that on some front, to get those data sort of described in trials and to get subgroup analysis by OA and some other things. I think it's important to raise the issue. I'm not sure it has impact on your outcome, core domain outcome set development.
So is it a contextual factor that we should include in when we're thinking about that? Is that the place to put it?
It's maybe more than contextual, right? It's a significant concomitant comorbidity that exists in some X% to Y% of CPPD patient. And the day we do a nice epidemiological study, we'll have X and we'll have Y. We don't have X and Y. And I'm going to defer to Anne and Geraldine for that. But if OA is coexisting in 80% of chronic CPPD patients, then it becomes humongously important to have the subgroup analysis. And if for any reason it's 30%, it's still very important, but not critically. I'll let Anne sort of address that.
Yeah, so let's open this up to the group. What do others think?
Well, since Jazz called on me, in our VA study, which had its limitations, but it was about 85% of the CPPD group. So I think it's probably more than 30 or 40. I'm not sure it's as much as 80. But I think it's a very common. And it's a little different than OA because I mean, in RA, because RA clearly causes premature, disease in the joints that it's affected, and whereas CPPD, it may be sort of simultaneous, particularly in the genetic form. So, there's something pathogenetically that needs to be understood there.
Thank you. Courage, you've got a comment. Would you like to share that?
Yeah. Okay, thank you. I was just listening to Jazz about the pathophysiology, and I think that, yeah, even though they are coexisting and the pathophysiology may have impact on the outcome, but the domains you are going to measure in terms of the outcome are not likely going to be different. So you're still going to be looking at psychological effect, you're still going to be looking at joint destruction and all of that. So I think the domains will still be about the same.
Thank you. Leanne, you've got some comments on the chat?
I mean, I think the question for me is what, particularly pathophysiologically, that primary OA of the knee, which may be difficult to differentiate from when there's chondrocalcinosis present, but wrist OA, which shouldn't happen in a primary form and can certainly happen from CPPD, should those be considered differently than sort of
what do you think? What do you think?
I mean, they're different. For me, they're different diseases, and though that they may contribute towards physical function impairment similarly, I'm not sure that they should be considered in the same bucket.
Owen and David, what's your view? What's your lived view?
I was going to comment that I think if you're doing trials on CPPD, the associated features are the secondary kind of diagnosis. If you put OA in that or put acute flare-ups in that, I think it's decide what you're investigating. If it's CPPD, I think they should all be put together and we shouldn't separate OA and CPPD.
I was just going to say that Jazz's point is absolutely brilliant. If you're thinking that OA and CPPD are pathophysiologically caused one by the other, and there's a different biologic feature that'll cause that, as opposed to patients with RA who then, when they're older, get OA, I think that's fascinating. I would just tend to measure it and mention it. I guess that's your contextual point, that you're mentioning that CPD patients often have OA. The point is going to be important in 10 years, or hopefully sooner, with Dr. Rosenthal and others, and when we get better treatments. Because the treatments, of course, are narcotics, analgesics, and then gout treatment, except for the prevention with allopurinol. So I would tend to say just mention it and not necessarily have it as a separate trial domain question.
So I have a straw man, Nicola, for the group that you just thought of. How about a general thing saying, going back to Anne's comment that in the VA study, 80% or so people with CPPD also had OA, that when you come up with a codomain set for CPPD, that you indicate that since it's such a large majority people have OA and that there may be a pathophysiological connection between the two, that we recommend that every trial of CPPD present subgroup data by OA presence, and when possible and when feasible, measure OA outcome domains as well, separately if they are separate. So what you're doing by that is making one as when needed, because subgroup in a data analysis you can always do. The pharma companies don't like to do that, but if you push that, they always can do that as a secondary analysis. So by that, you at least get one, and then you say, well, if feasible and possible, please also report the OA outcome domains for people who have CPPD and OA. So that way you would have actually gone one step further than where the RA community is with fibromyalgia, where they're thinking about these things, and you'll be 2 steps ahead of them 22 years earlier in the disease. And so that's what I would say.
Okay, thank you. Now we've got some other really good comments in the chat from Maria, Tristan and Will. Feel free, you three or anyone else, to make some additional comments, and then I think we'll have a summary from Ken coming up pretty soon.
Well, it just seemed to me that when you showed the OA domains, they were very similar to what Ken showed in the scoping literature review. So I'm not sure at a practical, pragmatic level that the CPPD domains will be that much different from OA domains, but what might be different is the way you measure them. And I'm particularly thinking about imaging instruments.
Right, yeah, yeah. And we should acknowledge that the UNRACT ultrasound group has already developed CPPD ultrasound domains and done work on that. So that's separate work to this group that's already been started. Other comments? We've got some. We'll record these from the chat. But anyone else who wants to make a specific comment before we just show the summary from today? Great. Okay, so our next, we're just going to have Ken show us a discussion now. Ken, you can probably share your screen, and or you can just give us a summary, however you want to do it.
Sure. Well, because I guess we've only got a couple of questions, it can be fairly straightforward. Let me see if I can share the screens just to make things a little bit clearer.
Yep. Great.
So just, I guess, in terms of the summary of the first question, and these are the voting results from should we develop different core domain sets for different CPD clinical presentations, and 76% people said yes, 24% no. And really, I think the main kind of theme that came out was probably separating the two kind of groups into more short-term studies looking at kind of acute CPPD crystal arthritis versus longer-term studies, which may include an overlap of things that include chronic CPPD and crystal arthritis, OA with CPPD, and people that have acute flares. Part of the underlying problem is probably related to the fact that we, at the moment, have quite limited treatment options for people with kind of chronic or long-term CPPD. And people wanted to emphasize that there's quite a significant difference in terms of the disease course of CPPD compared to gout. And there's that lack of clear relationship between acute and chronic CPPD. And so there was also the point to make that was with so much overlap between the different CPPD clinical presentations, it may be challenging in the future to recruit similar patients for clinical studies because most patients quite fall into multiple categories at this point in time. In terms of the second question, which was CPPD and OA often overlap and how we should manage this overlap, I think the general consensus appears to be that there's very much a recognition that OA commonly occurs in many conditions, including CPPD. And we need to acknowledge this in our CPPD studies, but it doesn't appear to necessarily affect how we're going to develop our core domain set. There's a lack of clarity at the moment between what the pathophysiological relationship is between OA and CPPD. And there are many different forms of OA, which are not necessarily the same as an example, which was mentioned, wrist versus knee OA. And so potentially in our future CPPD studies, the OA core domain set may also be reported as a subgroup analysis. And that was a very good suggestion that I think a few people agreed with. So that's it from me.
Thanks, Ken. That's really great. So I think we've got a couple of other comments from Maria as well around actually related to, I think, Will's comment as well, that actually the domain sets for imaging biomarkers for OA and CPPD and also PROs as well. So that point around, even if you're measuring the same core domain, actually the instruments, as we kind of get further down the line, may be actually different. So we can't necessarily just assume that what we're doing for OA or what we're doing for CPPD is necessarily going to be the same for OA. Okay, so I think that actually I'll just share my screen again just to show the last slide. Which is just really the summary, and then to say thank you to everyone. Thanks to all of the members of the CPPD working group. If you would like to join our working group, we have more work to do. We're going to be doing our Delphi next, and hopefully coming back to an in-person meeting maybe in 2022 to vote on our core domains. So we really hope that anyone who's interested, please contact me or Sarah or Abhishek. Would really love to have you. Any